Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Farden. I'm the chair and organizer of Grand Rounds, and it's a real joy to me today to introduce today's speaker. John Dick is known to a lot of people in this audience physically here today. It's nice to see colleagues old and new, people who've returned specifically for this talk. So thank you very much for coming. It's really nice to see you. This is actually, I think, the third in a row Grand Round we've had back in the Gannick. It's really actually, all it being a bit of a pain having to come from my office up here, it's quite nice to meet in person, isn't it? So it's very nice to have you here. And we've got obviously a number of people on Zoom as well. So thank you very much for joining. John Dick, if you don't know, was a consultant vascular physician, general physician, all-round good egg. When did you start here? Some time ago, he'll say. So it's certainly here when I got here in 2003, so a long time ago, and fulfilled a number of roles, including general medicine TPD. He was my TPD when I was a registrar, clinical director for medicine, as well as being a mentor to a number of people in this room, I think will agree, and a valued colleague to others. And he announced a number of years ago that he was going to leave. And so I said, well, you must come and give a grand round if you're going to leave. And I dragged him kicking and screaming into this very spot to give a grand round, which I think it was a packed audience, and which is reflective of the esteem in which people held you at the time and still do. And looking back on that, there was a certain, what we would now call burnout, perhaps, yes. What we would call, at the time I thought was perhaps just being grumpy, but I think really genuinely was a burnout as we now know it. And he was off to Australia. I thought, well, that'll be him gone and I'll never see him again. And then he phoned me up a few weeks ago after a favor, which I was delighted to give. And I said, well, whilst I've got you, you must, if you're back in the country ever, you must give a grand round. In fact, why don't you just do it from Zoom, on Zoom from Australia? Well, actually, I'll be in the country. I'm coming back for the St Andrews symposium. I'll be in Scotland. Brilliant. Let's tie it in. I still had to drag him kicking and screaming to do this, but he's going to talk about his time in Australia. I think it's very timely. In medical education, there is a mass exodus of our trainees to go, particularly to Australia, because the grass is greener over there. It's a real problem for us. I think there's some insights that he'll tell us about why perhaps it is greener in Australia. And always entertaining, always a pleasure to hear from you. I'll share your screen and on we go. Right, spontaneous round of applause for John Dick, everyone.
Thank you very much. And that introduction wasn't quite half as embarrassing as I thought it might have been. But anyway, there we go. Yeah. Oh, thank you very much, everybody, for coming, and for those online as well. Australia, the lucky country, and the question mark is valid, but we'll just keep going for just now and see how we're going. Is it right click to move on, Tom?
It's first left or right.
Yeah, there we go. What am I going to talk about and why? So Townsville, which is where I am.
I've just turned the volume up.
Okay. Perennial problem whenever I'm doing
perennially softly spoken.
Yes. Still got the big stick though. Townsville, which is where I am, what the geography is, what the healthcare is, what our challenges are, something about Australian healthcare, what's good and not so good, and some fun stuff at the end about the sort of perception of Australia as being a lethal place to be. But anyway, there we go. It's a big country.
Don't mind me. I'm just going to sit with this so we can actually see what the hell's going on. There we go. Try that.
Right. Okay. Good. It's a big country. That's most of Europe fitted in, as you can see there. And you can, if you, Will's in the audience, United Kingdom, not the Republic of Ireland, you can fit 7 of those into Queensland. Interestingly enough, about 80% of Australians live within about 50 kilometres of the sea. So it's actually a ribbon of population around the outside. Just for fun, that bottom right-hand picture that bottom right-hand picture is a potential road trip from Townsville to Mount Isa, which we service with secondary services. And it's 900 kilometers and a 10-hour road trip if you did it all in a oneer. So people snicker when you say Townsville because they all assume that the Australians ran out of imagination. But actually, it's named after Robert Towns. There was a search for a port north of Rockhampton because the Burdekin River floods, and the Ross River and Ross River Creek between them provided a port area. So it was founded in 1864. Towns visited in 1866. He agreed continuing financial support, which got them the municipality status, and it became a city in 1902. Towns only came that once, and he didn't like the place, but they didn't change the name. And that's his headstone from his grave in Brisbane. One of his relatives replaced it with a more grandiose affair. He was a man of means. And the local town petitioned to get it for their own purposes, and that's the top of Castle Hill. Population of about 180,000, largest military base in Australia, big army base. It's got brigade strength, but it can take a whole division, which tells you a lot. Air Force Base, they fly FA-18s out of there in case the Chinese come calling, and they're getting F-35 soon. And the Navy, the Navy base is because the port of Townsville is deep enough to take their big brigade assault ships, and it's the only one north of Brisbane that is. It also takes cruise liners. I think Calm dropped in a while back. Agriculture, livestock, sugar, grows sugarcane and tropical fruit to the north, and grows a lot of market vegetables and melons and things to the south. There's zinc, nickel, and copper in the hinterland, which tells you, if you're following, that they're 3/4 of the way to making batteries. The university is JCU, James Cook University, world-class marine biology, and has medicine, nursing, and allied health schools. The USP of the medical school was that it raised or trained rural generalists and rural GPs, and that's still the main focus. And you still find, or we still find, that our students are a lot more savvy about the practicalities of life and medicine than some of the balloted students we get up from UQ or Bond or Griffith. And then there's administration. It's an administration hub because Brisbane's so big. So the state government offices, there's Great Barrier Reef Marine Park Authority, and there's the Australian Institute of Marine Sciences. So it's not a backwater, even though you may not have heard of it. Townsville Hospital and Health Services covers 148,000 square kilometres. It's a retrieval services Queensland Northern hub, the other one being in Brisbane. Cardwell is 160 kilometres to the north. We service that. Bowen is 200 kilometres south, and Hughenden is 380 kilometres west. Magnetic Island is only 12 kilometres east, but the ferry stops running at 10 o'clock. And Palm Island is 65 kilometres to the north. So we've got 5 helicopters and a 6th one provided by RACQ, which is yellow. And they're all those. So Augusta Westland 130s, if anybody's interested. The Hospital and Health Service has 20 facilities in total, including small facilities out in these areas. But TUH and 7 others are actually within the city boundary. We've got 720 beds. It's the only tertiary level hospital that's not in a metro area in the whole of Australia. 200,000 catchments local, 250,000 for the Hospital and Health Service, about 350,000 for intermediate services, and for the high-end stuff, cardiothoracics, clot retrieval, etc., it's over 500,000 spread over the kind of area that you see there. It's a point of work, yep. So down to Mackay. Central Queensland kind of divides because it's not too far down into that southeast corner. This conurbation is 3 million or so out of the total state population of 5.5. It's maybe closer to 3.5 now. And what do we do? What do we provide? Apart from this fantastic view, we do everything. we have the largest single-site ED in the state. We do cardiothoracics, neurosurgery, we get all the polytrauma, we do clot retrieval. We're getting renal transplant next year, which is very exciting. That's been 6 years in the making, and it will be the first new transplant unit in Australia for over a decade. And it will bring Queensland up to having two transplant hospitals rather than just one. We have an MRI LINAC, no cancer doctors in the room, but we got the first one in the Southern Hemisphere. What do we not do? We don't have a gamma knife for neurosurgery. We don't do severe burns. They go to a specialist burns unit in the Royal Brisbane. And we don't do heart or liver transplantations or lung transplants. What are the challenges? Well, our geography I've just spoken about. Workforce, recruitment and retention. Still quite a lot of people think of us as something of a backwater, even though we aren't. If you want to go anywhere, you have to go to Brisbane or Cairns first because they have international airports. But there you go. But a lot of the workforce issue is perception. We have a challenge with demographics, the same as you do, except we're about 10 years behind. So that 200,000 catchment, there's about 25,000 of them are over 65. And by the end of this decade, it'll be 42,000. Expansion, and that's why I've put that image up there. This building does not exist. This is an artist's drawing. But that's our ED there, and it's to be built. Townsville has a master plan signed off in 2017, designed to be a hospital of the future by 2050. It's several billions worth. One of the standalone blocks is that West Block, and it's due to be completed between 2035 and 2038. But the plans are all there. At the last state election, the Labour government promised that they were going to put another $1.5 billion into Queensland Health. And we all assumed that that meant building another hospital down in that southeast corner, probably somewhere between Logan and Redlands, or maybe even knock Redlands down and rebuild it. After the election, when they got back in, they came up to us and said, West Block costs $530 million. Here's the $530 million, build it now. We want to commission it in December 2026. So that the two challenges there are building the bloody thing, staffing it, and the fact that $530 million in 2017 doesn't bought more than $530 million now. It's 2 floors of wards, 1 Jerry's, 1 rehab, 140 beds, a big day case procedure unit, 4 theatres, allied health, and some offices. And how we're saving the money is we're only going to kit out 2 of the theatres, and we'll leave the other 2 as shells for just now. So expansion is a challenge. Disaster resilience is a challenge as well. We've had 3 disasters in the last 5 years. We had a near-miss cyclone, I think it was called Clarice or Candice or something like that, which hit Bowen instead of us. It was aimed for Townsville, but like a lot of them, with the clockwise wind direction you get in Southern Hemisphere cyclones, as soon as it came close to land, it kicked off south. So it missed us, but we were all ready for it. Then we had the floods due to a monsoon overcoming all our flood defences. And then we had COVID. This building and the others like it are proofed against cyclone. The hospital buildings can withstand a direct hit from a category 3, which is 100 to 125 kilometers an hour. And the core bits of the building can withstand a direct hit from a category 5, which is 200 to 250 kilometers an hour. And you have to build that in. And then our last big challenge is Indigenous health. And I've only got 1 slide about this, but I could actually do the whole lecture just on this. We talk locally in Townsville about Aboriginal and Torres Strait Islander people, or ATSIs, or alternatively First Nations. In terms of percent, Queensland has 4.6% of its population is ATSI. Townsville, though, is 8.4, Cairns is 9.7. And Palm Island, that I mentioned there, is 91.4. That's a particularly dark period of Australian history where the land was cleared of 3 different Aboriginal tribes. They're called mobs. They didn't get on with each other, and they were all parked on Palm Island to get them out of the way. They're all still there. Well, a lot of them are anyway. The disease burden amongst ATSIs is immense. This is a self-reported survey, and they have poor engagement with health, so you might not find, well, this will be underreporting. Respiratory diseases, a lot of asthma, a lot of other lung diseases. This is not TB though, 14.5%. Mental health problems, 12.5%. Diabetes, 6%. And the diabetes is particularly aggressive. Like a lot of hunter-gatherer peoples, ATSIs evolved to withstand a protein-calorie malnutrition diet. And then when you give them a normal calorie or even high-calorie, high-protein diet, they get type 2 diabetes very early, not necessarily being particularly obese when they get it either. And so you see type 2s in their mid to late 20s on dialysis, and they're not fat. Now, some of that is poor health literacy, and some of it is the genetics of the ATSI peoples. Generally, the life expectancy is between 7.5 and 8.5 years less than the non-ATSI, than Caucasians and other races. This is a very old slide, but I thought it was very elegant, so I've stuck with this one because it's all put it together on one slide. It's 2006. It's probably got worse. This is how many people per 1,000 are carrying a disease burden. Okay, and in Australia, the quintiles operate the opposite way to the UK. So the most advantaged are quintile 5, and the most disadvantaged are quintile 1. And you can see there's a gradation, and that's about 50%. You can also see that non-Indigenous peoples are about the Queensland average, but Indigenous peoples, 285 per 1,000, over a quarter of them carry some sort of disease burden. So what are the problems? By the way, these are 2 crown of thorns starfish munching their way through this coral, and that white scar there is where they've eaten already. Polyps have been killed. And even though I've only been there 8 years, in terms of scuba diving, even I've seen a difference over that 8 years with the bleaching and the crown of thorns infestations. Anyway, aging population, and in particular the provision of healthcare in RACFs, in nursing homes. GPs are paid by footfall. The footfall payment doesn't cover the cost of being able to go into an RACF, see 3 or 4 patients, then come out again. They operate at a loss when they do that. So they don't do it because they're a business. The chronic conditions, the same big 4 that we have in Scotland, account for over 1/3 of our hospitalizations, more than just about 2/3 of the total disease burden, and 87% of the deaths recorded in healthcare. We've got increasing costs, doesn't everybody? We're living through an era of overdiagnosis and overtreatment, which is multifactorial, but it's the same kind of factors as you have here. Dr. Google, medical legal environment, insecure, more junior practitioners, etc. Growing out-of-pocket expenses, no, explain that in a second, and increasing private health insurance premiums so that less than 50% of people under 65 now have private health insurance. And then the healthcare for First Nations there. So what's good? Well, that's GDP per capita. It's 20 and 22 data, 21 being removed because of COVID. And you can see that Australia is actually 3rd, $55,900 a year. That's the UK down there. $49,000, so $6,000 per head more. Australia has a same top rate of taxes in the UK, 45%, but it kicks in earlier in your tax range. And they spend about 10% of that on health. So there's more money in the system. Medicare, let's talk about money, so how's it paid for? There's a Medicare levy in your tax bill. It's hypothecated. So that money is all going into health. It's not enough, so some of your general taxation money goes into health as well, but you know what part of your taxation is all being spent on health. You can rebate some of that, you get a tax break against your private health insurance, which encourages you to take private health insurance. The healthcare system operates with a public-private mix, and the coined phrase for that is social market medicine. The big thing for everybody in this room, and presumably for a few people on Zoom as well, is this realistic remuneration. We just signed MOCA 6. I'm not going to tell you how much it is, not in a public lecture, but if you can ask me afterwards, I'll tell you how much I'm getting paid. But roughly speaking, you'll get between 1.5 and 2 times an NHS salary for doing about the same kind of job. Why is that? Because social market medicine means that you can go and work in private practice. And if they don't pay you a decent wage for doing your public medical stuff, you won't do any. Nobody's forcing you to. So the remuneration is good. The whole structure of it is different as well. If you work overtime, you get AVAC and you pay the overtime. It's a very different system. And it actually produces results. This is life expectancy at birth. I've tried to flag. Unfortunately, I made Germany blue, and that hasn't really come out very well. So that's the United States there. So running at 76 or so. There's Germany and the United Kingdom here. They both make it over 80. And there's Australia there. It's about 83. But another way of looking at this is years of life lost once you hit 65. So you're having a useful retirement, third phase of life, call it what you will, or are you pegging it early or gibbering somewhere? This is per 100,000 people, and this is thousands of years of life lost, okay? And you can see that the US loses just under 8,000 years of life years of 100,000 people over 65. UK's here, Germany's here, Australia is here, okay? And when you look at who's ahead, Israel probably not on point at the moment, but Luxembourg, Switzerland, Sweden. Luxembourg and Switzerland are very rich. Sweden, different healthcare model. Iceland, different healthcare model. Korea and Japan, partly genetic. And Spain just does things better at the moment. Where we fall down, though, is suicide, mental health. Again, a big ATSI problem, but also a problem amongst young white men. And we're not doing terribly well there. How does Medicare work? Medicare guarantees you universal access to free healthcare in a public hospital. It funds the public hospitals. It funds a pharmaceutical benefits scheme, so your prescriptions are either free or greatly reduced cost. And it funds medical providers. Most medical providers are in private practice, which includes all GPs. So that's useful, but the problem is that it's a fee-for-service system. So the GPs are paid by footfall, not by outcome, and not by keeping people well. So that's a big problem. There's a scale system, medical benefits schedule. You can diverge from that, but you need to be able to justify why you're going to charge somebody more. And there's a fixed rebate through both of these systems. That's where the money goes. And you can see that's government versus non-government versus state government. Sorry, the other way around. Hospitals, primary healthcare, where the Australian government, federal government, pays the bulk of primary healthcare. These are other referred medical services, etc., etc. Not much goes in research. By the way, that's thanks to Kelly for letting me pinch that slide in this one too. The bulk of the funding is federal. 45% of it is direct, 25% is by transfer via the states. The states depend on that money to make the thing work. Hospitals are run by states, but they're jointly funded by federal and state, and they use these two models, activity-based funding and then work activity units. I don't have enough time to go into these, but suffice it to say that as a system, that sucks. Basically, if our unit underperforms on WOW, then we get our budget trimmed next year, or we get hauled over the coals. If we do better than our planned WOW, we get a pat on the head, but we don't get any extra money. We made $10 million extra last year in internal medicine, but it's hypothetical. They are looking at changing that. Otherwise, it's yeah. Anyway. Private hospitals. Anybody can set up a private hospital, but the states license them, so you can't charge money through Medicare unless you've actually got a license. And the federal government regulates the insurance of the private hospitals, so then they have to perform. The feds pay for primary care. So now you see the big problems that are emerging. And then you talk about the out-of-pocket payments, which is about 15%. Here's the money going up. This accurate data, I think Kelly put this together about 3 years ago. This accurate data stops in 2011-12, but it will be going up. That's the state and territories share. This is how much individuals pay themselves. This is how much the private health insurance pays. So you can see that people are paying more and more out of pocket rather than using insurance. So it's a very siloed system. There's the publicly funded healthcare. There's a private system. There are service providers. Imaging and laboratory services in the community are all private. The primary care networks are an agglomeration of private people. Psychiatry services are separate. Community services are separate. And there's a thing called the National Disability Insurance Scheme, which is a good idea, but is mired in bureaucracy. These all work separately. They're not interlinked. There's no communication between the two and between any of them by computer. If I admit a patient on a Saturday who's seen a private cardiologist earlier in the week and had their medication changed and they can't remember what it is, and now they've got renal impairment or heart failure or whatever, it'll be Monday till I can get the private notes out to find out what that doctor did. So the funding model is poor because of the state versus federal split, this work activity units thing, and the fee per item of service. Here are the 10 building blocks of healthcare, which are aimed at primary healthcare, but for healthcare in a system. And if you look, the NHS does nearly all of these, but doesn't do prompt access to care because it's underfunded, but there is an attempt to cover all of these bases. Australia, GPs aren't impaneled, patients aren't impaneled. And of all things that I've found irritating working there, it's the fact the Australian Medical Association lobbies against impanelment because they say it limits patient choice. Quite getting better at data, but as I said, there's that siloed effect. Population management, it's not that they're actually managing the population, but they can't redistribute workforce to enforce that. Continuity of care, you can doctor shop twice in 3 days and they won't catch up with each other for a week. Team-based care, very patchy. Comprehensiveness and care coordination, I've just explained how it's all split. And template of the future, it's a polite way of saying that none of this is actually working at the moment. And Australia can't continue to maintain the waste, the variance and the harm that they're doing to their populations by operating this siloed system for another decade or more. There is a chance that this will change. A Labour national government, a Labour state government, but we'll have to wait and see. Other things not so good, medical training. Foundation year 1 and 2, not tight. By the way, that's a stonefish, which is a typical grumpy bugger, and doesn't really harm you, but if you stand on it, the spines across there give you, inject you with a poison that you will remember for the rest of your life. It won't kill you, hurts a fucking lot. Foundation 1 year and 2, not tied together, but they're not, okay. Variable, 1 year at RMO and SHO level, then you go into basic physician training, 4 terms per year, 2 specialties, 1 internal medicine, 1 relief term. It takes you 2 or 3 years to run through the program, and then you sit the exam. The RACP exam is part 1, 2 written papers, multi-choice, and part 2, the clinical. Part 1 is twice a year, February. We change house the second Monday in February. Exams always at the end of that week. So the entire medical universe rotates around a bit like the Black Wednesday in the UK. And then they make them do the exam. Part 2 is in October, which doesn't really help because the clinicals are only held in late June, July, and August. You only get 3 attempts at each. So here's a high stakes clinical exam that you need to pass in order to proceed in your training. And you can only do it once a year, fail 3 times and you're out. And the exam itself is alarmingly random. It's 2 short cases and 2 long cases. And your 2 examiners don't get told what's wrong with the patient. They're told the patient's name, and they have to go and take their own history and do their own exam and then compare it with what you come up with. The problem with that is there aren't enough general physicians in Australia to run that exam properly. So the first time I was part of that, I was the observer, and one of the short cases was a spinocerebellar ataxia. And the 2 examiners, who were an endocrinologist and an oncologist, a cancer doctor, decided it was MS. And I sat there for a minute thinking, well, do I tell them? And I did. And they said, oh, thank you very much. We're really struggling with that. And that's the examiners. So we have very good people who fail this exam, who shouldn't. And we do have a couple of people in my lifetime there who've passed, and you wonder how on earth did they get through. Having made you go through that torment, your advanced training is 3 years in specialty. And it's a scoosh. There's no exit exam. You turn up, you do 6 6-month blocks. If you do dual accreditation, not enough people do it. It's about 4 years. It's a time-based assessment with very soft assessments and a bit of a chat at the end of each 6 months. There's no e-portfolio, and there's a logbook for procedures, but not much else. So they front-loaded the stress, and at the end, it's just walk through the system. So if you're thinking of moving, number of things to bear in mind. MRCP doesn't count. The Royal Australasian College of Physicians does not recognise MRCP. It recognises fellowships, but not memberships. So if you come with MRCP, you will still have to do their BPT and their exam. If you want to come for a visit, and it's a temporary thing, probably the best time to come is somewhere between PGY 3 and 4. Probably go through an agency, because they'll help you with the visas and everything. You get a 2-year visa, and you can do that RMO role, which is like SHO junior registrar. If you're doing it as a break in training, particularly if you want to get the training counted back home, again, a 2-year visa, but you'll need to find a program. You need a contact and a target. Tom has my email address if you want to help hand with any of that. Not necessarily to come to Townsville, just in general. And then if you're coming permanently, or at least for like 5 years or something, come as a consultant, which they call staff specialist. You will be assessed as a UK grad by the RACP as substantially equivalent, and you get 1 year supervision on the overseas trained physician scheme, which is basically a bit of a chat once a month and then signing the paper as you go through. unless you're rubbish, in which case it's a very different thing. That's the only mountain biking picture that I put there, but that's a trail called Under the Radar, Tom, and that's looking across the Magnetic Island. That's a World War II machine gun emplacement, and that is my hardtail, which is a Trek Roscoe 7. Now, some fun stuff. And I've requalified as a scuba diver when I went over there, and that's now my main recreation. The practice of medicine is very much like ordinary UK medical practice at its core. So we still see lots of heart disease, lots of stroke, COPD, diabetes, liver, gastro, etc., and the various diseases of the elderly. But we do see some things that are totally unexpected. Rheumatic fever in young people, disseminated gonococcus and gonococcal arthritis, very aggressive diabetes that I spoke to you about, and very aggressive connective tissue diseases. The other thing about ATSIs is they have a 6-fold increase in lupus. Don't know why. And other things too. And then some things that I've written you've never seen, but you probably have seen a few, but not that many, I would imagine. Melioid, dengue, and lepto. So I've got one each of these just to talk through. This is melioidosis, Burkholderii pseudomai, an environmental gram-negative bacillus. Tropical disease. The one case that was in Paris on the world planner and map on WHO was a botanist who got sent a bromeliad sample from Australia and worked in the botanical gardens there and caught melioid from the sample. It's contact with wet soil or with water. It's inoculation through a skin break or inhalation, and it causes what we call wet season pneumonia. There's a 20-fold increase in melioid in diabetes. We're not entirely sure why. So much so that if you get somebody with melioid, you check that you do their diabetes screening when you get them. It does disseminate very quickly and forms abscesses all over the place, and about 1/5 of men who get melioid will get a prostatic abscess. And if you don't look for that, you don't find it. I know Tom's wincing. And the treatment is ceftazidime or meropenem for 2 to 4 weeks, and then trimethoprim sulfamethoxazole for at least 6 months, maybe a year, if they're immune suppressed. So our wet season pneumonia medication, you come in, you get IV Kef and oral doxy while we're waiting to get speciation. That's what we do automatically. Before I came, we had a husband and wife both come in with melioid. She came in first. That's not actually her, but it's very similar to her. As you can see, she was intubated, and she died 3 days after presentation. He came in 4 days later with melioid and was convinced he was going to die, but actually had relatively mild disease and was okay. And you don't get person-to-person transmission, so we presume there's something in their garden that got both of them. Dengue. Dengue is an arbovirus like Zika or Japanese encephalitis. It's transmitted by that little thing there, Aedes. You can see it's fed, stomach full of blood. Symptoms 2 to 14 days after you've had a bite. You get a fever for about 7 days, and then you recover. You get headache, myalgia, arthralgia, a rash, itch, GI upset. There's a very small number, less than 5%, will go on to get really severe dengue. They get dengue shock, which is widespread capillary leakage. And sometimes they'll bleed as well. You get dengue hemorrhagic shock, which people don't do well. There are 5 local serotypes. Once you've been infected with one of those serotypes, you're immune to that serotype for the rest of your life, but it doesn't protect you against the other 4. You can still get them after about 6 months. And in fact, if you get one of the other ones, it may make it worse. You get this antibody-dependent reaction and a cytokine storm. and lepto. Gram-negative spirochete, very characteristic appearance, getting contaminated water and biofilm. Mucous membrane entry or a break in the skin, symptoms 2 weeks or so after the infection. Headache, fever, myalgia, and abdomen pain, but no rash. If you get a rash, you think, okay, well, they've got dengue then. Second phase, jaundice, renal impairment, and meningoencephalitis. 5 to 10% get severe disease, and I've called it hepatorenal, but it's hepatic and renal, really. And then there's a very small percentage of them get pulmonary hemorrhage, and if they get ARDS with that, they have about 50% mortality. We treat that with doxy, or if they can't take oral, azithro for 2 weeks. My first bad dengue was my first full weekend on call without one of the others backing me up. And it was a soldier who'd been out on exercise out west, was with 2 RAR, fit guy, Lance Corporal, who had a known diagnosis of lepto, and his renal function was going off a little bit. And the Army sick bay said, we're just a bit worried about this guy. Can you admit him? So he came in, and he came in on Friday evening. I knew about him. I saw him on the Saturday morning. By that stage, his creatinine was 300, but he was otherwise well, and he was sitting up chatting to me. And at 3 o'clock in the afternoon, Ellie Hothersall, the ICU consultant, had to crash intubate him on the ward and take him up to ICU because of the pulmonary hemorrhage. Young, fit guy. 2 weeks later, he walked out. And 3 and a bit months later, 10 weeks later, he's back in my clinic saying, can he get signed back as A1? Because he's on light duties until he's, yeah, so amazing. And then lastly, a little tour de force of some of the things that are a bit more aggressive. This picture, that's a baby quokka. This picture is actually photoshopped. Somebody's put a cheetah's mouth on him. They don't have, quokkas don't have canines because they eat roots and seeds. Anyway, there are things that can kill you. Crocodiles, sharks, snakes, spiders, jellyfish. This is the Strand, which is 100 meters from where I live, so I can walk to that very easily. That's the Fisherman's Pier on the Strand with the Lady of the North there, whose temperature, the temperature of the seawater affects her color. So she's red there because it's hot in the sea. And that's a stinger, a warning sign. And then that's where they put the crocodile signs. Okay. Recent croc sighting in this area. Don't go swimming. We call them salties, saltwater crocodiles. They're an apex predator. They do ambush attacks. They don't need to be hungry. They will attack anything, because what they'll do if they're not hungry is they'll kill you, drag you, and wedge you under a mango root in the swamp. They're widespread across the top end, and they are migrating south. They're like estuarine, brackish water. They're quite comfortable in the sea. Adult male, 500 kilograms, about 5 meters, big. Females are smaller, 100 kilograms, 3 meters. They're a bit more, I was going to say lightweight, but they could still do you an awful lot of damage. We get 1 to 2 deaths per year, but far more attacks. Croc's teeth, eating decomposed flesh, plusher and brackish water, all the bites, all of them get badly infected with absolutely everything. They wind up on Cipro. The Port Douglas one was particularly sad. There's an 82-year-old lady up there at the RACF in Port Douglas, or one of them anyway, who went for a wander and wandered down through the scrubland and to the local creek. They found her stick and her shoes. About 10 days later, they identified the croc that they thought had done it, and they euthanized the croc, and there were bits of her inside it. not normally a hazard for a wandering elderly patient in Dundee. Sharks. Now I scuba dive, so I have a great interest in this. But they mostly go for surfers because they think you're a seal. So you're on the surface, you're splashing around in a black wetsuit. Okay. They only need one bite to realize you're not a seal. And in fact, they don't like eating humans. They don't like the taste. But if you're a great white, that one bite is usually fairly damaging or even fatal. When you're under the water, and in particular when you've got a tank on, the shark's electromagnetic detection system tells them that you're not a seal. And moreover, you've got something on your back that they're not sure of. Their reaction to that is to kind of look at you and circle a bit, but they don't attack, he says. Bull sharks are just aggressive, and they are the sort of wild men of the sea. They'll attack anything, even when they're not hungry. One fatality this year, sadly, a 16-year-old girl in the Swan River in Perth. That's the first fatality they've had there for over 100 years. It bit her legs, and one can only assume it severed a couple of major arteries because she died at the scene as they were pulling out of the water. And then tiger sharks, which are aggressive and territorial. So if you see a tiger, you get out of the way. Unlike other sharks, tigers, when they lay their eggs, will stick around and protect the egg cases. So they guard the nurseries. There is a nursery between Palm and Magnetic Islands, and nobody in their right mind goes in the water that area. No fatal or other tiger shark attacks 2023 so far. Snakes. I like this poster. It's 1950s. Common snakes of Brisbane backyard. It's quite common to have a deadly poisonous snake in your backyard in Brisbane. There you go. 3 that we worry about. The eastern brown, which has a very highly toxic, it's the most poisonous snake in terms of the toxicity of the venom, but it's got small fangs and it doesn't deliver a big load. So it's quite unusual to get seriously envenomated by an eastern brown. A coastal taipan has very nearly the same level of toxicity, milligram per milligram. It's much more aggressive, and it does multiple strikes. It will come for you and bite 3 or 4 times in one dart. So you get more in, and it's quite unnerving. And then the red-bellied black, which is this one down here, that whenever it is bitten by red-bellied black, they're ever needed out. That's what it was, because of the distinctive appearance of it. They're not particularly aggressive, but they like living around human habitation. So you do come across them quite a lot. It's a less toxic thing. It's a big snake. This one gets up to about 2 meters. It's one of the few snakes here that likes to eat other snakes. Envenomation, between 1,000 and 3,000 bites per annum, of which about 500 are sufficiently severe that you get antivenom. Should have brought a picture, I'm sorry, but we have these snake venom detection kits where you swab around the bite site and you put it into this multi-well dropper dispenser system, and it will light up with which kind of snake bit you. That's from the venom, not from what's inside of you. So it's not an indicator that you need antivenom. It's an indicator of, if you need antivenom, which one it is. We do have the polyvalent stuff as well, but there's a slightly higher increase of incidence of anaphylaxis with the polyvalent, and about 2 deaths a year. The last death in Townsville was a man who tried to pick up an eastern brown from his patio using his Weber tongs from his barbecue grill. He did have heart disease as well, so it wasn't going well for him. And he did say to the paramedics, they said, why on earth are you picking up an eastern brown? And he said, I thought it was a taipan. Why that makes it better, I have no idea. Anyway. Spiders. That picture is actually a cheat. It is a real spider, and it is eating a mouse or pulling a mouse up an appliance there. But it's a huntsman. It's not toxic. They're big, they're scary to look at, but they won't bite you. And even if they did, you just nip a bit. Anyway, funnel web spiders, we don't have them in Townsville, it's too hot. But they are unpleasant. The male's quite large and will go hunting for females at a certain time of year. So then they're not in the webs, they're just walking around the place trying to find a Saturday night, I think. And only about 12% or so of bites produce envenomation, but it produces a neurotoxin and a catecholamine surge, and it's very unpleasant. There is an antivenom, and since that was introduced, there's only been one funnel web spider death in the whole of Australia, and that was a kid. Redbacks, though, they're like black widows, but with a red back. They like sheds and outhouses, characteristically making an appearance in the dunny, the brick-built outhouse toilet, midnight visit, and the spider makes an appearance at the same time as you and bites you somewhere you'd rather it hadn't. You get a lot of pain at the site of the bite, very rapid onset of systemic symptoms, but no deaths. Antivenin, though, does give pain relief. And so we keep large stocks of it because if kids get bitten and you give them the antivenin, they get pain management very quickly. And lastly, jellyfish. Three main jellyfish that we worry about. Australians call it a blue bottle. We've known it up here as Portuguese man of war. That's the one with the big sail on the top and the long venomous tendrils. It's very painful, it's very scarring, won't kill you, but you regret that you met it. Box jellyfish, very different. They like brackish water, they're estuarine, they're active, they've got eyes and they move after things, and they tend to go in little groups. If you get stung by a box jellyfish, it is absolutely excruciating. I never have. I've never even seen someone who has, but I've spoken to a diver who was on a boat when somebody got stung. And he was in agony until they got him ashore and got IV fentanyl. And he was still screaming with the fentanyl on board. It's really very unpleasant. And then Irukandji, named after the tribe, the mob, north of Cairns, where these stingers were first discovered. They're tiny. They're only about a centimetre long. And the sting that you get is apparently trivial. It feels a bit like a mozzie bite. But about 30 minutes later, you get Irukandji syndrome, which is catecholamine surge, dangerous hypertension, and an overwhelming sense of impending doom. Nobody's figured out what the toxins are, but IV magnesium helps all the other symptoms. So we get quite a few of those. The other thing is that people die in the water of heart attacks. And you usually find some gloom monger that says it was an Irukandji sting. And everywhere you go, you'll see these vinegar bottles to help if somebody does get envenomated. And that's a different view of the Fisherman's Pier and the Lady of the North there, with the Brisbane Harbour, with the Townsville Harbour in the background. So November to May, you swim inside these stinger nets, which have the useful property of concentrating all the food in one place for the alligators and the crocodiles. And that gives you 95, 99% protection against whatever's in there. Oops, back. And that's all I had to talk about. That's a picture from Polaris Island of our dive boat. We camped on the island, sunset over the mainland. That's a picture of the long pier on Magnetic Island. And that was me with a near lethal mini moke, which I couldn't resist trying, but then I remembered why I'd stopped driving them in the first place. You do that and nothing happens. Anyway, there we go. Thank you very much.
Thanks very much, John. It's fascinating stuff, frightening in places. I'm jealous of you in some ways, and then you can. I'm happy to leave you to the other bits. So it looks like it that it's not all better.
No. Over the piece, it's better. Yeah, the workforce is happier. It's just that they've committed themselves to what I see is going to be an unsustainable model over the next 10 years.
We're running out of time, and people have to get to lectures, so I'm not going to have any questions just now, but John will be hanging around, I suspect. So if you want to say hi, if you've not had a chance to do that, then please come up afterwards, and he'll be happy to answer questions. If you've got any questions on Zoom, just send them to me. I'll forward them on to John, and we'll be able to answer them. I received a referral a few weeks ago of a strangely and unusual case of a man who was breathless when he was running around playing football, and the only thing that would help is if he would lie down flat. And he had a bit of a weird rash, and he had a bit of something else, and he had a slightly unusual set of blood tests. And I thought, I wish John Dick was here, because that's just the kind of case that we'd ask the general physician in the hospital, and that was just the sort of thing that we did for John Dick back in the day when he was still here. And we miss you, and it's really nice to see you. It's great to see what you're doing down there. You're still plugging away and helping people, inspiring people. I'm sure being a mentor to the people that you train in Australia, all those thousands of miles away, as you were to me and to various other people in this audience. So thank you very much for coming. When you finally retire, come back and do it again. All right, thanks so much, everyone. I'll see you next week.